Alrighty, folks, everything has started. Looks like Sonia might have froze, actually.
I was going to say that. Good afternoon, everyone. It looks like Sonia is frozen. So Sonia, if you can hear us, you may want to close and try to restart. So welcome everyone to our Project Echo session. Just give us just a few minutes. Look like we may be having some technical difficulties, and we'll get started in maybe a minute or so. We'll just see if Sonia can get logged back in. Okay, well, it looks like Sonia's having some technical issues, so we're going to go ahead and just get started in the interest of time. Um, so I am Selena Lowry. I'm the director for the Best Chance Network. I'm not with Comprehensive Cancer, but happy just to fill in for Sonia, my partner here. And so welcome to our Project Echo session. We have a great session planned for you today. And so I'm going to apologize to Dr. Khan. I don't have your wonderful bio that Sonia's worked so hard on. But today we do have Dr. Khan from the Shifa Clinic, who is going to be leading this Project Echo session. Just a reminder that this Project Echo sessions are recorded for your awareness. And we're going to, while we're waiting on Sonia, I think we should just jump right in. Dr. Khan, if you would please give us a brief introduction of yourself. That wasn't shared with me. So if you just want to introduce yourself, and then we'll go right into your presentation.
Sure. Good morning, everybody. And thank you so much, South Carolina Office of Rural Health, Sonia, Selena, for having me in this presentation. My name is Reshma Khan, and I am by profession OBGYN. I'm also the medical director for Shifa Free Clinic, located in Charleston, South Carolina. So I'm going to stop my camera, and we're going to dive into the presentation. Is everybody able to see my slide? Are you able to see my presentation?
Yes, ma'am. Looks great.
All right, good, great. So first of all, I want to express my deep appreciation to all of you in the audience, primary care providers, clinicians, and community leaders for the incredible work that you do every day for the patients across South Carolina. It is a privilege to be here and to share both the bigger picture of cancer survivorship and also our local experience through survivorship grant and the EHR enhancement pilot at Shifa Free Clinic. Our time together, we will focus on how we as primary care providers can strengthen survivorship and coordination for our patients. So as we begin, I want to set the stage for our learning objectives for today. These will give you a roadmap of what we'll cover, from understanding the continuum of survivorship to exploring case examples, and finally sharing some practical lessons from our own EHR survivorship project. So a little bit about the Shifa Free Clinic. We are a nonprofit clinic located in Charleston, South Carolina. We are a multi-specialty health service clinic who serve people that are uninsured and those that are 250% below poverty line, with multi-specialty clinic including primary care, OB, GYN, vision, and pediatrics. Last year in 2024, our average medical visits were over 4,000. We have an in-house pharmacy and also provide no-cost labs to our patients. In addition, we have a very strong hunger prevention program through which we have 4 different programs, including on-site food pantry, as well as outreach events, including health fairs and education classes, as well as back to school and turkey giveaway. Let's get started. So what is the definition of survivor? So according to the National Cancer Institute of NIH, a cancer survivor is from the time of diagnosis through balance of life. So there may be many types of cancer survivors, ranging from living with cancer through free of cancer. Now, let's begin by setting the stage with the epidemiology of survivorship. So as you see in this graph, since like in 2020 onwards, there were about, or currently in 2022, there was 18.6 million Americans are cancer survivors. That's more than 1 in 20 people. And this number is expected to grow to 26 million by 2040. Most of the survivors are long-term. 70% live 5 years or more, and over half live a decade or longer. So nearly 1 in 5 live 20 plus years after diagnosis. The majority of them are older adults, 78% are 60 or older. But survivorship isn't just about age. We also have a significant population living with metastatic disease, which is about 6,200,000 today. And this will increase further. Although this data tells us that cancer survivorship is not only increasing, it is diverse, long-term, and largely dominated by older adults. So our role as a primary care provider is more essential than ever to address the broad spectrum of the needs of these survivor faces. Now a pop quiz. So if Jordan can send up the poll. The question is, where does survivorship begins? At remission, at 5 years of age, at the time of diagnosis, or after treatment? I don't know, I cannot see the poll. Let me see if I can. See. So if you could take a quick poll on this one.
The poll is now shared in the chat.
So it is at the time of diagnosis. That's where the survivorship begins. Now, what is survivorship? So cancer survivorship is a state of being, including perspectives, needs, health, and physical, psychological, social, and economic challenges experienced by the people and caregivers after a cancer diagnosis. There is no phase or a kind of a survivor. Some have been treated for their cancer and some remain cancer-free, while others continue to live with cancer. The experiences and goals of care for each cancer survivor are unique and dynamic. The figure below depicts one way to think about different types of cancer survivors, including those diagnosed with early stage cancer or advanced cancer, or those diagnosed with or progressed to end stage cancer. Now, what are the components of survivorship care? So cancer, there are about nine different components of survivorship care. And survivorship care is really a whole person care for anyone who ever has had a cancer diagnosis. It begins with the day of diagnosis, follows the patients through treatment, recovery, and long-term health. But what does that mean in practice? It means that we as providers focus on these 9 different areas. The first is monitoring and managing late and long-term effects. Now, there is a difference between late and long-term effects. What is the difference? Long-term effects are those that occur during cancer treatment and persist after primary therapy, such as scarring. And late effects are those that are not apparent during the primary treatment, but arise later as a second, for example, it could be cancers from radiation or chemotherapy. Both types can negatively impact the quality of life of cancer survivors. So long-term effects are typically seen months or years after treatment, while late effects may not be noticeable until later. So understanding these distinctions is crucial for effective survivorship care. Second is watching for recurrence and new cancers. Survivors don't just face their original cancer. They often are at higher risk for second cancer, so tailoring screening is critical. Third, promoting healthy behaviors. Things like smoking cessation, nutrition, physical activity. These are simple but powerful tools that improve quality of life and reduce risks. Fourth is care coordination. Most survivors see multiple specialists, but their primary care often becomes the glue that holds it together. Fifth, managing comorbidities. Many survivors are older with diabetes, hypertension, or other chronic conditions, which make cancer treatment worse. Sixth, advanced planning. Survivors want clarity about goals of care, from everyday health goals to end-of-life decisions. Seventh, supportive care services. This is broader than medicine. It includes nutrition, physical therapy, rehab, sexual health, fertility services. dental and podiatry care, and more. Eighth is genetic risk assessments. For some patients, a referral for genetic testing is vital, not just for them, but also for their families. And ninth, social and financial realities. Survivors may face job loss, insurance gaps, or deaths of treatments. Our goal includes connecting them to resources that can ease these burdens. So in short, survivorship is a comprehensive, coordinated, and compassionate care, spanning recurrent surveillance, health promotion, comorbidity management, supportive services, social and financial well-being. So now that we understand how large the survivor population is and what's the role of primary care, let's dive a little bit deeper about what the role a primary care provider can take. Now, there are real challenges that exist in this role is we have challenges and opportunities. So the challenges that exist are care gaps persist, with some survivors missing essential screenings or preventative services, while others undergo unnecessary imaging and labs. Our own survivorship pilot confirmed this. We found fragmented data in EHR, poor survivorship identifiers, and limited communication between oncology and primary care. Patients also faced barriers that many did not, like lack of awareness. They did not realize why survivorship follow-up mattered, and financial constraints often prevented care. But there are also major opportunities. Primary cares are the consistent anchors across the survivorship journey. We can manage comorbidities, provide preventative care, and address psychosocial concerns. From our pilot, we learned that simple EHR enhancements, survivorship flags, templates, and integrated care plans made a huge difference. And equally important, empowering patients with education, linking them with financial navigation, tailoring care strategies builds trust and improves adherence. Finally, the oncology and primary care work in a shared care model outcomes improve significantly. We've just looked at a critical role that the primary care providers play in survivorship, from closing care gaps to coordinating with oncology to supporting emotional and social needs. But what does this actually look like in real practice? Let's walk through a few real-world case studies that highlight unique challenges survivor cares and how primary care can make a difference. So let's begin with our first case. This is a poll. So this is a 32-year-old woman who was treated for Hodgkin's lymphoma as a child. She received chest radiation at age 12, and now, 2 decades later, she's cancer-free and seeing her primary care provider for a routine visit. So we're going to launch the poll. So here's a quick poll. As a primary care provider, which of the following step is the most important? Do you start early breast cancer screening with mammogram and MRI? Focus on routine HPV testing? Simply reassure her? Or wait until age 50 for mammography? So I cannot see the poll. So we'll go with the answer. So early breast cancer screening, early breast cancer screening with annual alternating MRI and mammogram starting at age 25 or 8 years after chest radiation, or whichever comes earlier. Because women, why so? Because women who had chest radiation in childhood have breast cancer risk equivalent to the BRCA carriers. But that's not their only concern. Childhood cancer survivors who receive chest radiation or certain chemotherapy have a much higher risk of cardiomyopathy and valvular disease, sometimes requiring valve replacement more often than the general population. So the guidelines recommend having echocardiogram every 5 years, plus the cardiovascular risk modifiers like diet, smoking cessation, blood pressure, lipids, all. Second, radiation and chemotherapy can lead to fertility decline in early menopause or early menopause. So it's important to prompt these conversations early so patients can explore options. including specialist referrals, genetic counseling, or alternative family building options like IVF, donor eggs, surrogacy, or adoption. And don't overlook the psychosocial concerns, emotional health. Survivors often experience anxiety around tests and results. For some, this can be severe. So primary care providers can help by validating emotions, minimizing wait times for results, and connecting them to mental health support if needed. So this case really highlights just how important you are in a survivorship care. First, you provide continuity. You see patients, you see patients, many oncologists and specialists over the years, but you're often the only one who stays with them through decades. That consistency is powerful. Second, you make guidelines practical. Oncology may recommend early MRI or cardiac follow-up, but it is you who makes that gets translated into everyday care built into your patient regular visits. Third, you care for the whole person. Survivorship is not just about cancer. It's also about fertility, mental health, chronic disease, and the very human fears that come after cancer. You are the one who makes space for those conversations. And finally, you keep care connected. You are the bridge between oncology, specialist, community supports, and patient, so that no one feels lost navigating this survivorship. At the end of the day, survivorship care simply doesn't happen without you. Now let's go to a second case. This is a 61-year-old treated for HPV and oropharyngeal cancer 2 years ago. Is cancer-free now. Which late effect is most important for PCPs to monitor? Xerostomia and dental issues, hypothyroidism, dysphagia, swallowing problems, or all of the above?
All right, folks, poll is still live, so if you have any other responses, please go ahead and put them in now.
Dr. Khan, we're getting D's so far as the answer in the chat.
That's right. So D is the correct answer, all of the above. Now, these patients are at risk for dysphagia, which may require swallow studies and speech therapy. Xerostomia from radiation damages the salivary glands, leading to dental decay. So regular dental care and fluoride treatments are essential. Hypothyroidism is a common after head and neck radiation. So we need to check TSH at least once a year. And again, don't forget the mental health, depression, anxiety are often overlooked, which can have a huge impact on the quality of life. So takeaways from this. So this case really underscores the unique role that you play. You catch late effects early. Patients may not volunteer swallowing or thyroid issues, but you often pick them first. You protect quality of life by asking about dry mouth, nutrition, speech, mood. You prevent these problems from worsening. You support long-term monitoring. Even years later, thyroid issues or depression can emerge, and you are the one who ensures they don't get missed. And finally, you connect patients to resources. You guide them to dentist, speech therapist, endocrinologist, or counselors. So survivorship care is complete. In head and neck survivorship, your role isn't just about preventing recurrence, it's about helping people live well after cancer. So we've just walked through two real-world examples, childhood cancer and head and neck cancer survivors. But the reality is that these lessons apply across every survivor you see, no matter what cancer they had. So now let's shift gears and talk about the bigger picture. How to embed survivorship in everyday primary care. When we talk about survivorship, there's just not one way to do it. The NCI identifies a few different models, and the right fit often depends on the patient's risk and system resources. So in an oncology-led model, specialists continue to manage follow-up. This is common for high-risk or complex patients, but it can leave other health issues like diabetes or heart disease unaddressed. In primary care-led model, you and your team lead survivorship. You handle surveillance, preventative health, comorbidities, and quality of life issues while consulting oncology as needed. This model requires on strengths of primary care in continuity and whole person. And a shared care model is often seen as the best of both worlds. Oncology brings expertise about recurrence and treatment late effects, while you bring continuity and holistic management. Together, it ensures patients don't fall through the cracks. And finally, a risk-stratified approach customizes care. A low-risk survivor might transition fully to you in primary care, while a high-risk survivor stays with oncology or get more frequent specialist oversight. So the key takeaway is whatever model, primary care is essential. Survivorship is not just about preventing recurrences, it is about keeping people healthy for decades after cancer. So today we are focusing only on the primary care-led model. Now, the preventative care in survivorship is really just primary care, but with much higher stakes. Surveillance and screening. Survivors need routine cancer screening just like everyone else, but is often risk adapted. Screening for survivors often looks a little different than for general population. For example, a patient cured for colon cancer doesn't just return to average screening. They need colonoscopy one year after surgery, then 3 years later, and then 5 years. Breast cancer survivors need annual mammography and in some cases MRI. Prostate cancer survivors need close PSA monitoring every 6 to 12 months initially. And cervical cancer survivors with hysterectomy need pap smears of the vaginal cuff for at least 20 years. So this is where your role as a primary care is critical, knowing when to follow average risk guidelines and when to follow survivorship adapted guidelines. Then there is smoking cessation is the number one. Continuing to smoke after cancer treatment raises the risk of recurrence and second cancers. Even brief interventions from us as primary care can double the quit rates. Physical activity and nutrition go a long way in reducing fatigue, improving cardiovascular health, maintaining bone density, and supporting mental health. Survivors often need encouragement here, especially after weight changes and fatigue of treatment. Vaccinations are another key piece. Flu, COVID, shingles vaccine help prevent serious infections that can take a bigger toll on this population. And for younger adults, HPV vaccination reduces future cancer risks. Now, this table shows how the risk-adapted screening extends far beyond breast, colon, or cervical cancer. For example, prostate survivors need closer PSA monitoring. Rectal and bladder survivors require frequent local surveillance with scopes. Endometrial survivors depend on careful pelvic exams because most recurrences are picked up clinically but not by Pap. Testicular survivors need tumor markers and imaging. Thyroid survivors need ultrasound and thyroglobulin, and lung survivors need routine CT imaging. And for childhood and adult survivors, treatment-specific surveillance matters like echocardiograms after anthracyclines or audiology checkups after cisplatin. So these aren't one-size-fits-all guidelines. They are tailored, and the primary care is where these adaptations are tracked and carried out. Let's bring this to life with a few quick examples. So example one, breast cancer survivor with diabetes. A 58-year-old woman on an aromatase inhibitor after breast cancer also has type 2 diabetes. So the cancer treatment increases the risk of osteoporosis and cardiovascular disease, layered on top of her diabetes. So if we only focus on cancer surveillance, we will miss her hemoglobin A1C, blood pressure, and bone density. Example two, Hodgkin's lymphoma survivor with a CAD risk. A 45-year-old man, for example, treated with mantle radiation as a teen, comes in with borderline hypertension and high cholesterol. He's at risk of premature coronary artery disease, often earlier and more aggressive than in general population. Our job is to be vigilant about lipid management, blood pressure control, and lifestyle interventions. Example three is a prostate cancer survivor on ADT, androgen deprivation therapy. A 70-year-old man on long-term ADT is now osteoporotic and has metabolic changes. These side effects are not always addressed in oncology visits. As PCPs, we are the ones who order bone density scans, prescribe vitamin D and calcium, initiate osteoporosis treatment when needed. So these are some everyday examples that show how primary care is central in survivorship because comorbidities often impact quality of life and survival more than the cancer itself. So by definition, survivorship care is a shared care. Most guidelines like IOM, ASCO, NCCS, NCI state that oncologist is responsible for creating and delivering a survivorship care plan at the end of active treatment. But in practice, this often doesn't happen. But here's the reality. Despite being a standard recommendations, many patients never receive survivorship plan. Barriers include oncologist time, lack of reimbursement, poor EHR integration. Secondly, decisions regarding the need for shared care, mostly oncology care or transitioning to primary care, may be based on the type of the cancer and treatment exposures, comorbidities, and other factors. So a risk-stratified approach to survivorship may be necessary. For example, certain cancers, survivors with more complex and specialized care, such as head and neck survivors, would often benefit from multi-specialty and multidisciplinary follow-up care. So the take home here is oncologists should start the survivorship care, but PCPs sustain it. So while oncologists should initiate the survivorship care, PCP often have to activate and sustain it. So ideally, survivorship, these are some of the action and some tools. So ideally, as we said, it should come from the oncology team at the end of the treatment. But as we've seen, that doesn't happen always. And many survivors walk into our clinics without one. Happened to us several times. That's where primary care has a unique opportunity. We can step in to bridge the gap. Part of our role is to confirm, number one, whether a care plan exists or not. Document essentials if it doesn't. Just as importantly, empower our patients to ask the oncology team the right questions. Even encouraging the patient to say, can you give me a survivorship care plan during the next oncology visit can make all the difference. From here, let's walk through what PCPs can actually do in practice and one of the most powerful strategies in patient empowerment. These tools help survivors become informed partners in their care. You already know about the NCCN is a gold standard for oncology guidance, but did you know they often also offer patient-friendly versions too? And I have links for everything that you could download, or you can check into it and learn more from it. The NCCN patient guidelines provide clear guidance on everything from follow-up to healthy living. The ASCO survivorship care plan turns oncology guidance into a usable plan. The Cancer Survival Toolbox builds self-advocacy, especially helpful in navigating follow-ups. Platforms like Cancer Support, Community, and Patients Like Me connect individuals who often feel alone. Finally, tools like My Directives and Prepare you ensure that care preferences are captured and shared, empowering patients and simplifying your decisions. So it's a very interactive guide. When you have time, just go through this. I loved this particular resource. These resources are free, they're evidence-based, and designed to support survivors long-term, just one click or one scan away. But then, not all patients are computer savvy. So here's a brief checklist that you can provide to your patients. You can, sometimes we made this easy for us, because many of our patients are not so computer literate and not so computer savvy. So we put them on a PDF and say, these are the questions that you should ask your oncologist, and next time that you see them, and this helps us to make the patient aware and also get us the right information. So first is, and that was our thing. And number 3, first, document essentials. Just capturing the diagnosis, the stage of treatments received, and radiation fields in your EHR makes a huge difference. That information drives risk-adapted screening later, like deciding when to order colonoscopies, mammograms, or cardiac checks. Second, don't reinvent the wheel. Leverage templates like Journey Forward or the NCCN survivorship resources. These are free, evidence-based, and customizable templates With a few clicks, you can generate a mini plan that outlines late effects and surveillance needs. And finally, use your EHR tools. Build flags and reminders for things like mammogram, DEXA scans, or echo follow-up. In our own survivorship grant project, we saw that EHR prompts dramatically reduced missed screenings. The bottom line is with the 3 quick steps, document, template, and technology, PCPs can deliver high quality survivorship care without adding a huge burden. So as we wrap up, first, remember that survivorship doesn't end when the cancer treatment ends. Many risks from recurrence to heart disease to anxiety persist for decades. Second, you don't have to do this alone from scratch. Document the essentials, use templates like Journey Forward and the NCCN, and rely on EHR reminders to stay on top of the follow-up. Third, survivorship works best as a shared care. The oncologist may start the plan, but it's PCP who sustains it and ensures that nothing is missed. And finally, empower your patients. Encourage them to ask questions. Share the NCCN or ASCO patient tools and make patients partners in their care journey. With these steps, you'll not only help survivors live longer, you'll help them live better. And these are some of the references that has been used to create the presentation. So thank you very much for your attention and participation.
Dr. Khan, thank you so much for that. I'm sorry I crashed out on you very beginning. At this time, we'd like to ask if anyone has any questions. Feel free to come off mute and ask those questions or put them in the chat. And while we're waiting on any questions, Dr. Khan, thank you, because your information shared how important it is for primary care physicians in that gap that they feel. When, some years ago, one of our goals was to help bridge that communication from the primary care office to the oncology office. And just as you said, the survivorship care plans, treatment care plans, I think that's a great communication tool for patients, survivors, period, to, have that communication back and forth to both offices. And you all, just to remind you that Dr. Khan participated in a pilot where she enhanced her EHR systems to recognize survivors, again, patients who are in treatment and those who are in remission, and using that information to remind her who those patients were. She provided certain resources, targeted resources for them. So that was a great pilot, and she led a great effort that we've put out there as a model to other states. So again, thank you for that excellent presentation, as Natalie stated in the chat, and for reminding us of the great importance of the primary care roles that you play.
Thank you. Thank you so much for the opportunity.
Any other questions of Dr. Khan? Okay. Having heard none, we just want to remind you all to please complete your complete the survey that Glenn is going to put in the chat again. And I also just put in there the remaining sessions for Project ECHO. Dr. Khan, we invite you to come back and present to us anytime. So we have Laura who asked, Dr. Khan, is Shifa, am I saying that right, Shifa Clinic still providing BCN benefits for patients?
Yes, ma'am, we are.
Okay.
We also had Lisa O'Neill ask, do you think clinical oncology trials are beneficial?
Oh yeah, definitely. Absolutely. I've done the research on evidence-based strategies, and I was reading through a lot of the clinical trials that have been done, and I feel they are very important in helping us guide through the survivorship.
Okay.
I do have one question. How do you engage other primary care providers to basically work outside the box to focus on survivorship. You know, because a lot of primary providers see the cancer arena as, okay, this belongs to your oncologist, and I'm, you know, working on a different part of your health. How do you bridge that gap?
Yes. So, when we were starting the survivorship pilot program, I was in the same boat. I felt the same. Oh, this is cancer. This is, somebody, the oncologist has to deal with it. But when I understood survivorship care more, I realized the primary care is, we are the center for the patient to, as I mentioned in my presentation as well, that it's not so much about cancer. What we as a primary care are making sure that the patient's life is comfortable. They're not going through complications. We're managing comorbidities. We're connecting them to resources. So I think to get that idea for the primary care, that we are not to be so scared about the cancer part of it, but to see the patient holistically and see what the cancer has caused the patient, other problems, and to manage those. I think that was a survivorship. And I think to understand that part of survivorship helped us, or helped our clinic, to be a better cancer survivorship pilot program, or in a free clinic settings as well. In a free clinic setting, we have limited resources, but for those that have insurances and those that have other resources, it's much, much easier for primary care to do the survivorship program. But we could do it without those resources, and I'm saying it was very beneficial for us. So I think to understanding the whole survivorship concept, that it's not just cancer, it is all those other things that you're managing, those 9 different facets of patient's life, which we as primary cares are very comfortable doing it.
And Laura, I think we'll follow up with you after this session. You're asking if there's a line for patients to make their appointment. VCN will follow up with you unless Dr. Khan has a specific answer for her clinic, but we will get that information to you. So thank you for asking that question. Okay. All righty. Well, it's good to keep learning, Dr. Khan, and you have taught us very much today. Survivorship is so important. Quality of life, after treatment and remission and going through it. And your clinic is a great example of how to do that. So again, thank you for the resources that you've shared. And this has been recorded, and it will be placed on our website for anyone to go and review later. So if there are no further questions for Dr. Khan, we can end this session, and feel free to reach out to any of us here. Let's see if I can remember the email. I'll type that in. You want to reach out to us after this session to ask any questions, email us there at that email address. We'll get any questions that you may have for Dr. Khan after this, or if you have any for the Department of Public Health. You all have a great afternoon, and Dr. Khan, I'll be in touch with you because I have another idea that I'd like for you to present on if you're open to it.
Sure.
And yes. You all take care. And again, thank you for spending time with us today. Bye-bye.
Bye-bye.